Okay, you guys, I have a really, really cool interview for you today. This is actually a friend of mine, a personal friend who I know in real life. We've had dinner together with our families. We've drank a glass of wine together on multiple
Oh
occasions.
yeah.
And I'm really excited to have him on my YouTube channel today and sharing with you about his career field, which is he's a radiologist. So we're going to be really focusing on prolapse. So Dr. Giovanni Lorenz is a diagnostic radiologist, and he works at the Joint Base in San Antonio, Texas. He's an Air Force doctor, and he has granted us this gracious gift of his time today. He's a very busy man, but he's going to explain to us all about prolapse and what's going on, what it really looks like from an imaging perspective. I think we're even going to try to show some pictures so you can see. And this is going to be primarily directed at female prolapse, although we may throw in a little bit about male prolapse too, because that is an
Hmm.
issue. So
Yeah.
I'm really going to
Yeah.
let Giovanni kind of take over and maybe get us started, but I do want to begin with just what is prolapse, what is the basic definition. Giovanni, would you be willing to start with that for anyone who doesn't
Sure.
know?
Absolutely. Well, again, thank you very much for your time. I know that you're busy as well, and that you've got a lot of things going on, and I'm super excited for you and love checking in on you. Yeah. So, I think you approached me about this a couple months ago, and we had discussed what is one thing that you see, and what drove you into physical therapy and stuff. And same for me as a physician, I've seen that there are a lot of different things that affect people, from runny nose and broken arms. But one thing that is sort of not really much talked about, and thankfully you shed a lot of light on that with your book, has been the pelvic floor. And I think you do a great service for that because this is something that, one, it really isn't a lot of information out there. And I think you'd be very surprised as to how little information is known as far as the imaging, the management, and the treatment by some of the care providers that are out there. So the people who are listening to this right now may or may not come to a provider who knows much about this.
Yes.
And not only is that scary for the patient, but it's also scary for the physician because they want to do right, and if they don't know what to do, then that could be a disservice to their patient as well.
Yes, I think so.
But
And I was
yeah.
going to interject there that I know a lot of patients I don't think go through specific imaging. I think more oftentimes it may just be the patient thinking, finally going into their provider because they know something is wrong, and their provider checks them, usually by a physical examination, and they
Mhm.
say either, yes, you have prolapse, or no, you don't have prolapse, this is normal, don't worry about it, go home. I hear a lot of that, and
Absolutely.
patients say, or clients say, there is something wrong, and I know there's something wrong, and I was just blown off. And so I kind of want to share that as a story that I've heard so many times, and just sort of um, something for people who are listening to know that it is important to know that you may need to see another provider if you feel like you're being blown off. And there are options for specific imaging, like Giovanni's going to discuss with us, that may give you even better answers if you know something's going on.
Absolutely. You've hit the nail on the head there. That this is not something in your head. This actually is occurring. I pulled a few statistics. Obviously, this can occur at any age, any time, but typically we do see this, or more interestingly, more women tend to come to the physician. So it's sort of reported as more women, but I believe, and you've hit it there too, men can have this exact same thing too. Just typically men just don't talk to their doctors about things like this. But statistics that have been thrown around is that there's about 24% of all U.S. women, so a quarter of all U.S. women have some sort of degree of pelvic floor dysfunction.
Oh, yeah.
Um, this is, I mean, that's probably more than malignancy rates. That's probably more than coronary artery disease rates. I mean, we're talking a significant proportion of our population. So it's a big deal. And why is it a big deal? Well, because as you mentioned,
that's reported. That's reported because I've certainly read numbers that are higher than that too, and I think that that's true. What you were saying is that people aren't necessarily reporting it to their doctors. They're not coming in, and so it's hard to track exactly how many people actually have these issues.
Exactly. So we already know we have a problem that is already being underreported. 2, it's difficult to talk about, and 3, therapies are just coming online that can really take advantage of the new thoughts and processes that we're all trying to understand about the pelvic floor. Yes, the pelvic floor has been part of us for thousands of years, but we as care providers really haven't looked at it or haven't been able to think about it as a complex, holistic part of our body until just recently. In fact, until the last couple of years, I think it's become more mainstay. But as you mentioned, the physical exam is notoriously underreporting the pathology that is there. In fact, the physical exam is not really that sensitive to much of the pelvic floor dysfunction that we see out there. So I'll go into this a little bit later, but as a radiologist and as a physician, I would recommend that all women not take the first encounter as the one and only encounter to going through their journey with a pelvic floor evaluation. I think it should at least have some component of imaging to make sure that it's been appropriately documented and diagnosed. With that, so the problem. I think the pelvic floor is best described as a dysfunction, inappropriately balanced muscles that make up the pelvic floor. Sometimes this involves laxity. Sometimes this involves thinning. Sometimes this involves trauma. And trauma from birth, trauma from, believe it or not, constipation, or other things can really make a huge difference into the overall function and health of the pelvic floor. So it's a very big, unfortunately, broad definition, but we want to make it broad just so that we can then start then to capture as many people and then narrow down then what would be the best treatment option. Physiotherapy, which thankfully we have good people and providers like you to do that, or if needed, surgical correction and improvement. So I think that would be probably a good way. Pelvic floor is any bad juju that's going on down here that you're just not sure was there before.
Yeah, exactly. And it can be, like you're saying, all of those different things that could be going on, the laxity, even hypertone, like a hypertonicity, excess tension can actually be a problem too. So it's really, yeah, it's really interesting. So how do you do your work, and how do you do your examinations, and what do they look like? What are you seeing with people?
So just to remind everybody, the radiologist is a physician who has had approximately 5 years of generalized training outside of just medical school. So in comparison, a neurologist is 3 years, a general surgeon is approximately 5 years, and so forth. So we're at the higher end as far as the length of our training, and that's just because it's very difficult to read images. There's a lot of nuance to it. There's a lot of, we're dealing with radiation, so there's a safety component, and so we as the radiology part of your team, we are the ones who are going to evaluate what is going on, where the physical exam is just not that helpful with. Our imaging allows us to see inside the body and to see the function of that the component without actually interrupting the fascial compartments like a surgeon would. So to get to us, I think your primary care or your subspecialist like the urologist or the gynecologist would have to be interested enough to see what is going on globally. I think that's one way. We, as a radiology community, we have a lot of different ways we can evaluate the pelvic floor. And my personal opinion as a subspecialist, I think that the one that gives us the best bang for the buck, the best accuracy, and the best clarity of the imaging to begin to tell that story to our colleagues is the MRI. Yeah. And MRI is an imaging that's been around for about 30 years, 40 years now. It's the newest imaging that we've got, and it's got super spatial resolution, beautiful imaging, and it can really define the really small, tiny structures that are going on in the pelvis. We can take static images, which means we just take a snapshot, or we can take then movie clips. So as somebody is, for lack of a better word, peeing or pooping, we can see how that actually functionally works. And the mechanics behind it are kind of fun and interesting. And your clients and me as a radiologist, we come to know each other very well, very quickly during that exam.
Are you saying to me that someone's actually using the toilet during the MRI?
That's correct.
So this is a functional MRI then? This is what this is? Is that what that's called? Is a functional MRI?
It's actually called a dynamic MRI.
Dynamic MRI.
The dynamic aspect is that I'm just taking a movie as somebody's doing a function like coughing or moving their jaw or pooping.
But that makes so much sense because you don't live your life on an exam table or on an MRI table. You live your life coughing, pooping, peeing, doing those functions. That's brilliant. For prolapse examination, that's brilliant. Yes.
And so I think this is what you had alluded to earlier about the seeing many people and not getting the right thing initially diagnosed, because the physical exam, the talking about it, the other components of the history, they're not the dynamic part of it. Your patients, they find out about their problem when they're actually peeing or when they're coughing or they're laughing.
Yeah.
They're living life.
Yeah.
And so the only way we can see what that looks like is to recreate that scenario. And so now we're at the point where we can recreate that scenario during an MR examination.
So this is something, now I think cost-effective wise, this is probably something that's not feasible for every single person who has prolapse, but this is something that seems like it might really help tease out the extent to which the prolapse is happening for someone who's maybe there's some uncertainty, or maybe when would this be recommended? Because I'm assuming not everybody can have such an extensive exam, but when is this type of examination called for?
Absolutely. So in a perfect world, and in my perfect world, looking at how we arrive from the problem to fixing it, I think the MRI would be actually the most cost-effective, in my personal opinion. If you start totaling up then the amount of time, the amount of interventions, the amount of surgical corrections and stuff, I think it's important that we look at it globally and not just, okay, this is an expensive exam. Yes, it is. But it's an exam that will tell us the greatest amount of information and one moment of time. And I think that that's something that should be looked at. So you're right. Typically.
Yeah, no, that's so great actually though, because as I'm thinking about this here, as we're talking back and forth, this is very unscripted, everybody. I'm thinking to myself here, it does make sense actually what you're saying potentially in a perfect world, that when you're doing that functional MRI that's having you really see what's going on globally, you could know, okay, this person doesn't need surgery. Really what this person needs is to focus on strengthening the core muscles or work on coordination or down training one thing and up training another thing, versus just sending them straight to the surgeon's table, which so often happens. And we all know surgery is extremely expensive, plus the recovery process afterwards, plus there's a recurrence rate, a failure rate, potentially. We're not getting into that, of course, but it's a possibility with any surgery. So that is that what you're kind of am I reading you right? Okay. Yeah.
Absolutely. I think there are things that us as a community are a little bit slow into understanding. And so right now, what you're saying is correct. Typically, somebody would present to their family care provider, and a history and physical exam would be done, and then that history then would put them into a box. Is it a urology box? Is it something that has to do with the vaginal vault, the uterus, so they would see the gynecologist? Or is it something having to do with the rectum? So that has been typically what and how somebody moves from having a problem to where they go next, is then a referral to one of those very specific subspecialties. Now, in my personal opinion, as you've seen, the patients from the urologist, from the gynecologist, and then from the colorectal surgeon or proctologist, I can tell you that all the problem is still the same and it's still there. It's a pelvic floor dysfunction. And it's not just a urology problem and so forth. So I'm trying to advocate this, that we take a look at this from a global standpoint, a holistic standpoint, by introducing this term called a perinealologist, or somebody who's a specialist in the perineum or the pelvic floor. So I created a small little graphic, and it's on the, and hopefully you'll show this, but it is a graphic that shows the three components. It's the hexagon, and the hexagon shows a urinary problem, a vaginal or vaginal vault related problem, and then a colorectal or a colon problem. And what this hexagon shows is that it can be tailored to what the problem is that your client or the patient is feeling. Is it more urologic? Is it more from a gynecologic? And then we can then, once that's the case, I can then, as a radiologist, tailor my exam appropriately. So if somebody is saying they've never had constipation issues, I probably wouldn't spend so much time then focusing on maneuvers that are specific to the rectum. I would focus more on the act of coughing and bearing down to see and demonstrate then how the urinary bladder is holding itself up or being prolapsed down. Mm-hmm. So I think this is one thing. We've got to take a look that there's an entirety of components that are involved. Once I have a good roadmap through this use of this hexagonal graphic that I created, the next thing we can do then is then tailor the MRI. Now, you're right. You probably won't get an MRI on the first go. It probably does require then a referral to a subspecialist. I think what we can do, though, as a community, and what your patients can take from this, is that there are certain buzzwords. There are certain things to enhance, rather to ensure that your provider is aware of, so that then the appropriate next steps are actually being done. So when somebody says the word dysfunction, there's a lot of different meanings for that. But if they can characterize it in ways that mean how it affects their life, their day-to-day life, I think that's a good start.
Can you give us some examples?
So the frequency?
Yeah.
Absolutely, yeah. So if I were to say, I've had a problem for many years. This problem really doesn't affect me. That's a bit different than saying, I've had a problem that just started 2 years ago after the birth of my child. It affects me daily, every single time I go to the bathroom. Mm-hmm. It causes me much worry and concern and dysfunction in my normal day-to-day life. Mm-hmm. Those two types of histories are still accurate, but one is enhancing the frequency, the severity of the issue, and how it overall impacts their day-to-day life. That problem history will get more immediate training and evaluation than with the other type of history that's what's provided.
So to recap that, frequency, severity, and functional impact are the buzzwords that you're speaking to. That is excellent, and I completely agree. In my training, that's what we're looking for. But it is nice if the patient will just sort of, give it to us. That's very helpful as the provider. So,
you're right.
Yeah,
you're right.
Yeah.
Sometimes we do have to tease that out, but I can tell you that if we speak the same language, we're able then to get to the same goal, which is then improvement and cure of what's been occurring right now.
Yeah.
The other thing I would suggest in that first impression and evaluation is suggesting then that that perhaps this needs diagnostic evaluation. Mm-hmm. Diagnostic evaluation is sort of a general way of saying, I think we need to do more than just a physical exam.
Mm-hmm. Yeah.
I think most people in the community would appreciate that, and it would allow them to justify the referrals to radiology as well as to the subspecialist. And so I think that's a good thing for the patient to remember when they're in there.
Yeah.
Oh, and lastly, I think when discussing this, always write everything down. Write what you want to say and what is important to you in that meeting, so you don't forget it, during the encounter.
That is so true. And maybe even bring somebody with you so that they can be a second pair of ears, but definitely write things down. I agree. Write down your questions and then write down as you're talking, because you can get overwhelmed and confused and you can feel brushed off. But if you have your questions, then you can feel a little bit more firm in your resolve to get them answered. So I think that that's really a great point there. Yeah.
Absolutely. So let's say now that your client or patient has finally gotten to the radiologist. What we will typically do as a radiologist is that, and again, we're physicians, we'll take a moment to try to find the best protocol or the best way to evaluate the problem. And this is in a combination of what was written by the referring doc, as well as when we interview the patient. And yes, for something like this, we do interview the patient. I think it's important to get the patient's story, and so we can tease out what would be the best thing from our standpoint to better retell that story via imaging. So I think I have a good case, my first case here, and that case is, if I remember correctly, my notes say she was a 40-year-old female, and she came to us for evaluation of stress urinary incontinence. And so I think this is stress urinary incontinence is usually where people who do finally present, they come in with this. And this is a little bit of dribble, maybe a little bit of Valsalva related or intra-abdominal related pressure causing then an incomplete void or a voiding that is just doesn't feel right. There's, again, dribble. Mm-hmm. So we finally got her to come on in, and we did a dynamic MRI evaluation of her pelvis. And this image that I'm showing here, this shows, as you can see, going from the left side of the image to the right side of the image, two bright objects and one dark object in the middle. The bright object on the left side of the screen is the urinary bladder. That's water in the bladder. The thing in the middle is the uterus and the vaginal canal, or the bulb. And the thing on the right side of the screen, the bright thing, that is rectal gel. So before we did the exam, we inserted a catheter and we filled the rectum and the anus with gel. It's not gel that's going to hurt anybody or do anything, but what it does, it allows me then to distend the rectum like a stool, and to see then dynamically how that then flows through the rectum. On this particular image, this is a static image, so this is just her at baseline, not straining, not pushing, not doing anything.
It's a side view then? It's a side view image?
Exactly.
Okay.
Yeah, so this is the side view image. It's a we call it sagittal, but yeah, side view, absolutely correct. And we're focusing in, again, on the pelvis. And what to take from this image is that everything seems to be above, or at least on the same line. There's the pubis, which is just right below the urinary bladder, and then there's the sacrum and coccyx that comes down there. And so everything that is bright is above those two lines, or those two structures. And so that is a normal, appropriate function of just stable, and that's where usually people are. Now what I want to bring your attention to is the next image. These next two images are images of moderate strain and maximal strain. And by straining, I'm talking about going through the act of pooping or bearing down. Mm-hmm. And that bearing down maneuver is a maneuver that is trying to recreate either a cough reflex or the act of squatting, and so what we see here dynamically is we see a change of those two structures, the urinary bladder and the rectum, moving below the pubis and the coccyx. And so you can see a significant caudal movement. So everything is kind of dropping down or prolapse.
Yeah.
When the bladder does that, we grade it on a scale of 1 to 4. We call that a cystocele. And there are different gradings as far as to how bad the movement down is. In this particular case, her cystocele is probably about a 1 or a 2.
Okay.
In addition, what you can see on the other image is that the rectum and the gel within the rectum has moved down as well. And so that is a rectocele, a rectocele, and that's graded as well, and it's usually in a grade of 1 to 4 as well. And what I want everybody to get take from this image here is that without the act of dynamic evaluation, sorry to say it any other way, but you got to poop if you want me to see what's going on.
Yeah.
I would never have been able to diagnose not only the cystocele or the urologic specific problem, but also the rectal problem that is occurring there too. This harkens back again to our holistic evaluation of the pelvic floor. So instead of one problem being treated primarily either with physiotherapy or surgical correction, we've got now 2 problems that have to in concert be evaluated. And so this is very important. What do we do with 2 problems? Well, we try to do the thing that's going to fix both problems at the same time. And this is where you come in. Usually that means then strengthening of the pelvic floor, aggressive physiotherapy, which is not only the mainstay of many of our clients' problems and the potential therapies, but it's also something that bookends any kind of surgery. So before a surgery and after a surgery, physiotherapy is very, very important.
Yeah. Oh, that's great. I'm not able to look at the images right now, but I'm going to be inserting them into this later, so I'm really excited to look at these. Was there another image that you wanted to show us, Giovanni, before we sign off for the day?
Absolutely, yes. The final one I think I want to show is something that I've been working on recently. The final image is on something called the competitive organ. And the competitive organ theory is something that I've been looking at. This is labeled implications case number 1.
Okay.
This is a theory that not only do we have one problem, but we have several problems. And one of those problems may actually mask the severity of the other problem. And again, dynamic MRI evaluation is, to my knowledge, the only way that we are able then to evaluate this this competitive organ problem. So let's say again, we see that there is a cystocele.
Again, that's a bladder prolapse, so a bladder prolapse, okay.
We have then a rectocele, so again, some sort of prolapse of the rectum. Mm-hmm. But what we notice then is that sometimes one tends to overrun and undermine the severity or the overall evaluation of the other one. So in this particular case here, you see the rectum has prolapsed so far down, it actually is masking how far and how well we can accurately grade the cystocele.
Okay.
In my personal opinion, this particular image shows to great degree how then we are under-evaluating and under-treating several problems. We are seeing the biggest problem, which is the rectocele, and that would probably be a grade 4 rectocele.
And in the image,
but we're masking.
Giovanni, can you describe the image right now, just in case it's unclear for anybody, like where the rectum is on the image? Because I'll put it up.
Absolutely. So this image is another side view image, and what we see going from left to right, we have an orange arrow pointing on in the area of the urethra, which is then being kinked and obstructed by the very large bright thing in the back of the body, which is the rectocele. Okay. So the rectocele is so large, it is coming in and going around and kinking and stopping the urethra, as well as then stopping the descent of the cystocele. So I have probably a patient who doesn't have much in the way of dribbling or stress urinary incontinence. She probably has incomplete defecation and constipation. But if that were treated with a surgical correction, she would have immediate, very quick stress urinary incontinence and difficulty with her urine, which would be considered then a surgical problem or a post issue with the surgery, when actually it was being masked by the severity of the other problem.
So it's almost like when the rectocele is corrected, the floodgates are going to open because it's no longer kinking the urethra. Oh, that's great. Okay.
Absolutely.
I mean, it's not great, but this is coming together in my brain is what I mean. So, okay. Yeah.
So what I want to get across again is that as a radiologist, I know we may not be the first nor the last, but we are, in my personal opinion, we are one of the more important steps in this journey. And that the imaging tells a story that is able to be told to all of the people involved, especially the patient. And if any patient has the opportunity to go and do this exam, I would highly recommend then going through the exam with the radiologist. I would be more than happy to discuss this with patients, and I do this often. I think this is something that we can provide. That then helps everybody understand what is going on. It helps then to better appreciate what the problem is and how best to treat it. And in my personal opinion, it also helps to unmask some of the fallacies we know about pelvic floor correction, that it's just one major problem, instead it's a holistic problem, and that treating one thing actually will, like you mentioned, open the floodgates to other things. So if we have a better idea in the beginning, then we can do the best approach possible.
Yeah.
So again, I think in this very limited time, hopefully everybody's gotten across that it is a big problem. It's an underreported problem, but don't feel bad and don't feel that there's nothing you can do. In fact, there's a lot we can do together as a team to figure out how we can evaluate that problem and then how then we can get it corrected.
Yeah. Oh my gosh, Giovanni, this has been wonderful, and I've really enjoyed getting this insight, since you're my friend, into your personal world and your working world. Giovanni moved away from where we were located together. Gosh, it's been 3 years now, or has it been 3 years?
4 years.
4 years.
Oh no, I think it's 4 now.
Oh my gosh, it has been 4 years. So yeah, it's really neat to see where you are right now and what you're doing. So thank you so much.
Thank you.
Was there anything else that you want to wrap up with? Although that you ended that on a beautiful note, but if there's anything else or anything else you'd like to say, go for it.
Absolutely. So again, as a primary care doc before I went into radiology, I'm very much into teaching and education like you. And so I think one of the best things is to digest, think of questions, and then engage. And so I would hope that we can get this out to the greatest amount of people, so the commentary on this then can be further evaluated and engaged upon. And so there is good work out there being done by good people. And if the first person that you meet in your journey does not give you the most satisfactory results, don't fear. There are better and other individuals out there who can give you at the moment what's going to help. And I think that's something from the primary care standpoint, I believe is still very much important.
Yeah. Wonderful. Oh, thank you so much. I'm going to say goodbye. I'll let you say goodbye. I'm going to stop this right now, but thanks again, Giovanni. So see you later, everybody.
Bri, it's always good seeing you. Take care.
Bye.